Hey gang, and welcome to Module 6. So this particular class will provide you a lens for the rest of our class. Well, maybe not the whole class, but definitely the next several modules. So this is just kind of an introduction. I'll give you an overview of where we're going the next few weeks. Now, the last couple weeks of class may be a little different, but definitely the next 4 weeks this lecture helps you get an idea of where we're going, what to expect. So let's jump in. Let's jump into Module 6 and see. Let's share my screen here. Make sure it's the right one. Okay, hopefully that's the right one. So this is Module 6. This tells you kind of what we're looking at, what we're doing. Here's the Module 6 outline. Let's pull that up. So we're going to discuss and compare different trauma-related approaches. Now, you're not going to learn everything about all these approaches, but you are going to learn about several, or at least be introduced to them during this module, and be thinking about what they look like. So I'm not going to go into nauseating detail about what each one looks like today, but we will go into quite a bit of detail over the next few weeks. And then we'll kind of want to look at matching trauma-specific treatment methods with relevant populations. You want to read Chapter 3 in your textbook, and we'll do a discussion board this week, as usual. And so here's our lecture. And you have an overview, and I'm just giving a really broad overview of treatment approaches. So we'll take a look at children treatment approaches, children techniques, and adult techniques working with trauma. And this right here, I'm going to start at the bottom of our lecture outline. The reason I'm giving you this information is, well, there are many reasons, but the primary reason for you is to allow you a chance to assess for yourselves what each one of these kind of looks like in practice. So each one of the techniques we're going to cover over the next few weeks requires some intensive training. And I don't just mean like taking a class. I don't just mean like taking this overcoming child trauma class. I mean, it requires you to, like, for instance, trauma-focused CBT, TFCBT. That requires you to attend, week-long training, requires you to do 10 hours of online training before you do the week-long training, and then requires supervision, requires call-ins, requires direct supervision of what you're doing. And so, listening to sessions, documenting what you're doing in sessions, planning for sessions. They want to know that you can actually demonstrate the model. So you have to pay for that. Same thing with PCIT, Parent-Child Interactive Therapy. You have to pay, at last check, that's about $1,000 to go and do that. Now, and there are particular steps that you go through to do that. So we'll learn about the steps. We'll learn what the therapy looks like. You won't be able to deliver the therapy. Now, there will be certain aspects of TFCBT that you'll be able to deliver. We'll talk about that. And that's why I'm sharing some resources with you. I'm not sharing them all, but I am sharing certain resources with you because I do think it's important. And we're gonna really battle this week talking about the value of evidence-based practices, which is what we're talking about in this class. What is scientifically shown to work? Our field really survives through scientific study, through empirical study, by observing whether or not what we're doing is actually effective, is actually working. There's some scientific research that says we may be missing a large component of what makes therapy successful by focusing too much on the tools. We're going to battle that today, or not today, but during the next week or so when we engage on the discussion board. So let's just jump in a little bit more. This course offers, and each approach varies. Each approach has its own training procedures, its own requirement, and its own cost. So again, if you're going to invest in something after you get, if you're really like, yeah, that really looks like something I want to do, that's a population I want to work with, then yeah, you might want to jump right out of school where you just invested thousands of dollars and invest another $1,000 or so in getting certified. Because getting certified, you'll be able to advertise, you'll be able to feel very confident in what you're doing because you've had this, training in a specific technique. We're training you to be therapists, well-rounded therapists. And this class gives you a look at, okay, if I want to go into a specialty, this is what I'll do, and this is how I'll do it. And this is how I'll work with people that have been through trauma. In some situations, you may encounter a job like I did, where they pay for you to go. And that's I worked for a community mental health agency, and they actually paid for trainers to come in or paid for me to go to trainings to be certified. So if you're lucky, you can land at an agency or a place where you don't have to pony up the money and be out that extra expense that you've already incurred, going through and getting your master's. So, but I do want you to be aware that this stuff is there. I will tell you, when I graduated with my master's in counseling, I was under supervision for a couple of years, and that was good. I was just trying to get my supervision hours knocked out, trying to make sure I had my license. So this may be something you don't necessarily, you may jump right out and want to do this along with your supervision. There may be some limitations to that depending on the technique you choose. In other words, they may require you to be fully licensed. But there may be other situations where you don't have to be fully licensed to get trained in the technique. But it may be a situation also that you may just want to wait until you're fully licensed. So anyway, just to kind of give you the overview, that's where we're going the next few weeks. Important knowledge for you to have. This course offers training and exposure, not certification. Please know that. I will share one technique that works with trauma, and I don't think I didn't share this. Again, there's a lot of different techniques out there that I'm not necessarily going to jump into. And so this would go under adult techniques, other techniques. So there's actually, this comes from Lisa Najovitz, and she put together something called Seeking Safety. And this is actually a manualized treatment. You can see I've got it tabbed. The student tabbed this for me. She really was enamored with this and actually went out and practiced right out of school. She bought this book. I believe this book is about $50-$60. But there is a lot of evidence, because the way that Najovitz validated her research here, she didn't necessarily make people go and be licensed to be delivering her technique. So this is really a lot of education-based stuff. It's less, in-depth processing and more here and now learning coping. Really big on learning coping skills. I'd put this in the cognitive behavioral category of a technique, but it simultaneously addresses trauma symptoms and symptoms of substance use disorders. So it's really good for folks that are presenting with co-occurring, dual diagnosis of substance use disorder and PTSD. Really a good resource. It's very self-explanatory, but it's actually not required that you do anything other than buy the book and very closely follow the instructions. So if you don't know how to do that very well, or you're not well versed. I'm actually a supervisor in this as well. I'm a trained supervisor in this. But if you don't know how to do that very well, you sacrifice rapport. You sacrifice the relationship with the client. And we're going to talk about that at the end of this lecture, why that's important. Okay, let's get into the others. So we'll talk about parent-child interaction therapy. That is next up for us, next module. Parent-child interaction therapy is really made for, and this is important, is really made for kids 6 and younger. Okay, so if you're trying to pick out a treatment technique, a treatment approach for a teenager, no, parent-child interaction therapy, PCIT, is not appropriate. It really, I would say, 7 is really pushing it. I mean, I guess you could have some 7-year-olds, 8-year-olds that are a little bit lower developmentally, but it's really trying to work on that bonding. So if you recall the number one from our last lecture, from our last module, the number one resilience factor is that supportive adult. This really helps parents who are having difficulty bonding with their 0, well, I would probably say 1 to 6, because it's really, obviously there's interaction because that's in the title, but really ideally probably 2 to 6, where you're trying to work on that bond, that oxytocin, that feeling of safety, security. Some parents are very overwhelmed. A lot of us have very busy lives, and parents may be stressed financially, in other type of relationships, whatever, may have their own ACEs that they're dealing with, that hypervigilance that keeps them from bonding with their kids. Very, very, and highly research-oriented, shown to help improve that relationship, shown to help improve the bonding. It's a difficult certification. It takes some time. It takes at least $1,000 investment and many, many months of training and supervision. So we're going to go over what that looks like. That'll be next week. But again, there's some limitations on that. Here, if you're interested in learning more, I did provide a link down here. Next, we have trauma-focused cognitive behavioral therapy, TFCBT. So TFCBT is, that's your textbook. So we'll spend some time. We'll spend probably a couple, 2 or 3 modules at least covering TFCBT. There are critics. There are also some really strong proponents. I may have mentioned I really became enamored with TFCBT because it integrated the idea of ACEs, and then gave me, at least in my own experience, gave me this comprehensive map of how to navigate kids that have been, treatment with kids that have been through trauma. And before that, I was just flying by the seat of my pants. I was just like, okay, let's be creative. Let's put this together. Let's try this. Let's try this. A really haphazard approach with clients. And I really, honestly, looking back, I didn't do service to clients. I don't think that I really necessarily did a lot of harm, but I also question the amount of good that I did, especially working in a psychiatric hospital for kids. That when a kid goes to a psychiatric hospital, you can damn well count on them having ACEs. And so I really feel strongly, you'll probably pick up on my passion going into this, that there are a lot of things that can really help you as a young clinician, and I'll share those. And so we'll take probably 3 weeks on TFCBT. Non-directive play therapy, I'm not going to spend a lot of time on that. University of North Texas is really renowned for their program down there. I was very fortunate to work with a couple of individuals that graduated from that program and learned so much about non-directive play. I was very skeptical going into, they were just play therapy. Yeah, that sounds nice. The way that it's done, and when it's done right, is extremely effective and extremely powerful for kids. So again, I can give folks resources if you're interested in learning more. I'm not going to share them here because I'm already exhausting you with a lot of resources. As far as adult techniques, really, and then a lot of work with veterans here with prolonged exposure therapy, PET. This is a lot, and it resembles a lot of TFCBT. And I really think that TFCBT borrowed its model, and I think its authors would acknowledge they're borrowing a lot from exposure therapy, because in creating a trauma narrative, which is the crux, the meat and potatoes of the TFCBT technique, the trauma narrative is what you do in prolonged exposure therapy. You create a narrative of what happened. And so you, as a therapist, help that person work through that narrative, picking on places where they're stuck, picking up places where there are a lot of irrational thoughts, irrational beliefs, irrational feelings. And so you can look at the resource here I shared, University of Pennsylvania, in the workshops. So again, that's a certification you have to go through to be able to deliver that. One that I was incredibly skeptical as a student, and even as a young professional, I worked with somebody who delivered EMDR, and maybe it was, thinking about this, maybe it was that person, because the person was, you meet some folks that are in the field that are a little bit off, and she had her quirks. She's a nice person, but she's definitely a little quirky, and she was a practitioner of EMDR. And so, I learned about it, follow, early on, you follow somebody's finger, and I'm like, okay, yeah, you go on and do that stuff where you're going to move somebody's eyes around. That's me in the middle 2000s. As time has gone on, and I've actually worked in the field for quite a while now, I've come to respect EMDR. And the research on EMDR, the way it developed was really haphazard. Just somebody kind of, it wasn't just brought out of a lab. It was somebody. We'll get into it when we talk about EMDR. But it focuses on the eye movement. And if you think about dreams, you think about when you have dreams, how easy is it for you to remember your dreams? It's not easy, especially when we wake up. We might have a dream that's really fresh on our minds right when we wake up. Then as we go out throughout the day, what happens? Kind of fades, harder to remember. Happens the next day. I don't even remember what I dreamt yesterday. And I know I dreamt something. And so EMDR, we've read that rapid eye movement stage of sleep where we have dreams. It really kind of plays on that in our neural wiring. So we'll talk about that. There are other techniques, as I mentioned. This is not an exhaustive list. In our discussion, if you have something else that you're like, he didn't talk about this, it's okay. Bring it up, discuss it. I want it. A lot of you are sharing resources. I'm very pleased with this. I love this when you guys are sharing resources, links. This is perfect. This is, I'm not an all exhaustive source of information. Now you may feel exhausted after you listen to me talk about information, but definitely don't have all the answers for all the information. So please share. This is another one. This is a really good way to link trauma and substance use, and it's manualized, but that comes with a price. Okay, so and I have some colleagues here at Adams State that are really critical and do not practice TFCBT because they truly believe it's counterproductive and it's hurting the client. And I think it's a combination of things. I think number one, it's a manualized treatment. When we get there, when I talk about manual, it's like a step-by-step thing. At least the way I was trained and supervised, there's quite a bit of flexibility. There's certain places where there's not flexibility in the model, but I found a lot of flexibility with it. You can be the judge when we get there. And this is one of the the questions here that Bruce Wampold asks. So this comes from the book 2001, The Great Psychotherapy Debate, the evidence for what makes psychotherapy work. It's this huge meta-analysis. Wampold looks at research. If you've never seen it, he looks at research from the 30s and 40s all the way up to the present, when he published it in 2001, looking for, okay, which therapy is better than another? We're like, okay, learn these theories. Okay, which theory do you practice from? What perspective do you practice from? Are you this? Are you that? Are you cognitive behavioral? Are you Rogerian? Are you Jungian? Are you Freudian? I mean, what's your, what's your slant? Where are you coming from? What's your theoretical perspective? And so Wampold really tried to look at all the evidence. So you can think about the countless hours of sifting through EBSCO and all these different sources. And Wampold tried to come up with, okay, which therapy is better than others? CBT would say, well, CBT is better. Look at all the scientific evidence behind what we're doing. But what Wampold found was that when you account for common factors, really, the approaches are pretty even. In other words, what Wampold is saying is that there are these common factors that are responsible for the change, that are responsible for people getting better. These common factors are what's really driving the effectiveness of therapy, is what's helping people get better. And so I would be remiss in this class if I did not bring up the research of Wampold, which I've shared. I share that here in our module. And this is part of your reading assignment this week for sure, is to read this article and kind of digest it, think about it, because it's the second half of your discussion. Here's your discussion post. Consider the evidence-based approaches to treating trauma. Again, you're welcome to bring in others that I didn't mention, because I know I didn't mention them all. There's a lot, and gosh darn it, there's so many interventions, and this is not a good thing for me to miss. There's so many interventions that are mindfulness-based that are coming out, either yoga or meditation, and those have a lot of promise. There's a lot of even neurological evidence that's showing, hey, these really work. And I'm not going to get into those as much, but these kind of Eastern medicine type of approaches, but they're really, wow, the networks that I belong to, this is really where people are gravitating to, these mindfulness-based treatments. And I'll see if I can pull one up. Maybe I'll modify the class a little bit, because really they're shown to be very, very powerful mediators of this trauma response, of these ACEs, of this cortisol, of this hypervigilance, of this constant battle between the remorse over the past and then with anxiety over the future, bringing people to the present moment, the safety of the present moment. That deep breath, letting everything go. They're so powerful, and those are some really necessary tools to have as a therapist. You'll get some of those in TFCBT. I think that's where I'll introduce them. Is TFCBT again? I find wiggle room in trauma-focused CBT, because it does give room to learn coping skills through breathing, through meditation, through yoga. Gosh, to me, there's just so much that you can do. But anyway, think about the techniques that we talked about, even some others that we may not have talked about. Which most closely aligns with your own interest or passion? What makes this approach stand out above the others? So just pick one. And which of the techniques appear most foreign, awkward, or aversive to you? Okay, and then please explain. And then I want you to also consider Wampold's research with the article there. What might be some of the driving goals and objectives in trauma-related therapy sessions? Because I don't want to lose track of that. Which of the aforementioned goals and objectives most closely relate to the common factors as understood by Wampold? Okay, that's your stuff. That's this week's module. Please reach out to me if you have questions. I know people are starting intensives. Again, if you're in intensives, you get a couple of weeks here. I'm tracking. I've got, thank you for emailing me. If you haven't emailed me, please let me know when you're going to be there at Adams. I'll be up there the next week, starting the 9th, the 10th of June. So look forward to seeing you there if you're on campus then. But if not, I'm sorry I missed you. Take care and reach out if you have any questions. See ya.